Hey guys, sorry I couldn't be there with you to talk to you personally today, but I was asked to give you a little spiel on Propofol. So as you know, the most important thing with any anesthetic is airway, airway, airway. So first thing you got to know is Propofol is mixed with and contains sodium soybean oil and egg lecithin. So anybody that has any allergies to either soybeans or eggs should use something different, not Propofol. They can have an anaphylactic reaction that could um, kill them. So none of that. So other than airway killing them, allergies to soybeans or eggs, you can usually have everybody survive a Propofol infusion. Important things to know that as soon as you give Propofol, there's a pretty profound atrial dilation, so they can have an atrial hypotension, which is going to result in low blood pressure for you to see. Usually it's self-relieved. You don't have to give anything unless it doesn't come back in a relatively quick time for you. That would be all on your clinical judgment as you give them the Propofol. As I understand it, you guys are going to be using it just for sedation purposes and in a drip form, not in bolus form. As you bolus Propofol, different things happen. You're giving larger boluses. You're probably giving 50 milligrams at a time, which is 5 cc's, which can really affect the that hypertension and respiratory depression that I told you about in the first place. If you're just going to start an infusion, actually, depending on the age of your patient, older people less, younger people take a little more. They can actually be sedated with as little as 5 micrograms per kilogram a minute on your infusion rate. I suggest and usually start my infusions at about 25 micrograms per kilogram per minute. Without giving any boluses, it's going to take a little while for that to sedate your patient. If you're not in a hurry, that's a good way to go because it comes on slowly. You can monitor your patient better, make sure they don't have that profound hypertensive episode, and they don't have apnea. You don't want them to quit breathing on you. Starting at 25 micrograms per kilogram a minute, depending how your drip pump goes, is not a substantial amount. So if your patient gets apneic or hypotensive, you're going to want to decrease that. Chances are you're probably not going to go lower than 25 micrograms a kilogram a minute for a healthy adult, even if they are older. So then you would increase it as you need it. I wouldn't go over probably 50 to 75. In anesthesia, when I'm giving somebody a monitored anesthetic, when I have them totally snoring silent logs, I'm probably only giving them 50 to 100. And you just want them kind of comfortable and sedated, so 25 is probably going to be good. If you had to go to 50, that would be all right too. Just closely monitor their respiratory status and their cardiac status, their blood pressure and their heart rate and things like that. And if they're start becoming apneic or snoring, and you can tell that they're having a little obstruction, usually all you need to do is just pull that jaw thrust a little bit, chin up, and get them breathing. If you're back there monitoring and taking them, transporting them somewhere, that's all you're going to need to do. If they're sitting on the floor and you got to keep them on this pump for a long time, then you don't want to have to sit there and do that. So decrease your rate until they can support their own respiratory status and hemodynamically stay stable for you. Okay, so our main concerns are going to be hypertension and airway control. And we said we're not going to give it to anybody that is allergic to soybeans or eggs. Another thing you have to be concerned about is pregnant mothers. Propofol does cross the placental barrier, so you're not going to want to give it to pregnant mothers, especially if they're going to be delivering anytime soon, because the baby is going to be sedated. And if we do it right before mother's going to give birth, that baby's going to come out in respiratory depression and not going to want to breathe. If it's mother that's not going to give birth anytime soon, then it's questionable, you can still give it. She needs a little bit more monitoring, including a fetal heart rate monitor. Nursing mothers, you don't want to give to nursing mothers either, because it crosses into the breast milk, and that also goes to the baby, unless she's going to pump, beforehand and then waste milk for, a day after getting the Propofol. So just another concern. On all the Propofols, of course, there's the guide, the administration guide that's in the pamphlet, and you can get all this information I'm giving you off of that same pamphlet. So start your infusions low and increase as you need to. For boluses, bolus doses really aren't going to relate to you guys, because you really shouldn't give bolus doses unless you're ready to intubate and ventilate that patient. I'm not saying that they all quit breathing, but many do. The bolus doses for emergency intubation, like in the ER, for adults is about, healthy adults, 2 to 2.5 milligrams per kilogram. Children are usually a little higher, 2.5 to 3 milligrams per kilogram. Elderly patients lower, 1 to 1.5 to 2 per kilogram. So it all goes on, age, size, fat content. Propofol is a lipid-based. That's why it's got that white emulsification that's in. It's in a lipid-based emulsifier, and it is distributed through the fat in the body. So the more you give, the more it takes to get rid of it or to have its effect. I guess this thing keeps sliding. I'm thinking I'm shrinking, but I'm not. It's just the little charger sticking in the bottom of it. So forgive me there. I was going to say something else about the mixing of the Propofol. Of course, it comes already pre-diluted in a little vial. There's usually 20 milligrams per cc. There's usually 20 cc's, or I'm sorry, 10 milligrams per cc, 20 cc's in a vial, so that's 200 milligrams per vial. It has preservatives, or has no preservatives in it, or preservatives that last 12 hours. So after 12 hours, you have to dispose of any Propofol you've opened, any Propofol in a syringe, any Propofol in a tubing line. It can start causing microbial growth and can cause your patient to be very sick or die. Some different recommendations. Some say dispose of the tubing every 12 hours. Others say, dispose of the bottle, the syringes, and flush your tubing every 12 hours. I guess I would err on the side of caution and dispose of any tubing and reuse tubing every 12 hours. So that's another big thing, is the microbial growth after 12 hours of opening a vial of Propofol. Another thing that can build microbial growth is sterility. You have to be very sterile when you open Propofol. Clean the stopper, a little alcohol, use a clean needle, a sterile needle that's never been used before, a sterile syringe that's never been used before. Puncture your new bottle of Propofol, draw it all out into a 20 cc syringe, inject that into your pump, however that's going to be. If it's a little bag, I actually use syringe pumps, so it pumps the Propofol right out of a syringe, and then when that Propofol is empty, I dispose of that syringe. When I take a new one, I open up a new one, or at least per patient, and per 12 hours. Alright, so let me see if I missed anything in my little disclaimer book here. Everybody's different. Everybody's going to respond different to Propofol. Some people take the minimum amount, some people take the maximum amount. Everybody's going to respond differently. That's why starting at 25 micrograms a kilogram is not a bad place to start. Decrease if you need to. More than likely you'll need to increase or stay right at the 25. Now starting at 25 mics per kilogram a minute, it's going to take a good 5 minutes for that patient to start getting really sedated. If you needed to, that person getting the 25 mics per kilogram, you could give a little bolus of 1 to 2, maybe 3 cc's. So you're going to give 10 to 30 milligram bolus, but you're going to have to watch those patients very carefully for hypotension and respiratory depression, and then start that 25 mics per kilogram a minute drip. So they'll get the initial sedation from the bolus, and then they'll go on to the infusion. Matter of fact, in the infusion parameters in the guidelines, it says that you can actually start your infusion at 100 mics per kilogram a minute until they start noticing the first effects, which is usually within a minute to 2 minutes, and then you titrate it down to your 25 mics a minute and see how they hold. Either one of those will be acceptable. Just remember to decrease your dose from 100 mics per kilogram a minute to 25 within a minute, or 2 at the most. Otherwise, you're going to have an obstructed hypertensive patient. All right, well, I don't really think of anything I'm missing here. Of course, you guys know I'm always available. This week I'm gone, but I am usually available, and if I'm not, right in-house, you can call me, answer any of your questions, give you any, advice I can, or come in and help you get it started. Okay, this is Tony, signing out. Good luck. Bye.